Hi, everybody. My name is Justin. This is the August session of the Journal Club for Wilderness Medicine. Today's topic is eye injuries and illnesses in the wilderness. We've got guidelines for discussion and then 3 journal articles. So whenever our presenters for the guidelines are ready, please take it away.
All right, so hey guys, my name's Jeff. I'm a current EM1 resident at Naval Hospital San Diego. Been working on my farm for about 1.5 years at this point, and I'm co-presenting with Matt Piechnik. He's a M1 over at Thomas Jefferson. I'll let him introduce himself though.
Yeah, nice to meet everyone. Yeah, M1 at Thomas Jefferson. Interested in emergency medicine and wilderness medicine.
All right, so as an intro, eye injuries and illnesses, they present several challenges in the austere environment. Limited equipment, limited medications, and also limited specialized training. I know the reflex when we see eye injuries in the emergency department is let's get opto on the phone, or let's go over to the eye room and get all the specialized equipment. But it's just a completely different challenge when you're in the wilderness where you don't have access to specialists. And also, I can't remember the last time I brought a woods lamp on a hiking trip. So, definitely makes things a little bit more interesting and difficult.
So for methodology, in 2013, a panel of WMS members who had clinical interest, research experience, as well as some ophthalmological expertise were convened, and they kind of did a review of the literature using PubMed and Cochrane searches, and they really just looked at ophthalmic injuries and illnesses. There's a pretty, as you might imagine, there's not too much research in the wilderness setting, so they pretty much adapted what they found in the general literature to a wilderness setting. And they made their recommendations based on the ACCP clinical strengths, which is the table there on the right. So 1 being the highest, C being the least amount of evidence, A being the most amount of evidence. So first things first, pre-trip planning and prevention. They recommended a few pieces of equipment that you should have as a basic in your basic kit, as well as some basic medications. And then truly, if you are experienced in ophthalmology injuries and illnesses, you can bring advanced equipment. But basically, the basic equipment was a light source of sorts, pen light, and ideally you'd have like a cobalt blue filter if you're going to bring fluorescein strips with you. Cotton tip applicators, paper clip for lid retraction, artificial tears, some erythromycin ointment for the eye, and then some proparacaine or local anesthetic, and then some oral pain medication as well. And then the advanced equipment, you want to bring some metal eye shield, magnifying glass, and forceps. Most of us have forceps in the kits, so that might be adaptable. A small needle, direct ophthalmoscope, wire speculum if you want, and then some advanced medications, which we'll kind of get into in their relevance in some of the diagnoses that we'll try and make in the wilderness. But fluoroquinolone, prednisolone, oxafloxacin, prednisone, atropine, pilocarpine, diamox, and some topical NSAIDs. So ideally, before the trip, you need to identify who has a history of eye problems, and they should have ideally an eye exam about 3 months prior to these trips, especially if it's going to be an extended trip. And everyone should be made aware of what the eye problems are. They should bring their own medication, prescription eyewear, sunglasses, just to stay prepared and offer the best outcome for your trip. Always bring protective eyewear if you anticipate some injury occurring. Good hygiene is super important to prevent anything from getting infected. And then hand washing is also paramount, especially for viral conjunctivitis or other highly contagious diseases.
All right, so eye complaints, there's a few different ways you can break these down. There's obviously a ton of different, diagnoses and complaints that you can have involving the eyes. So in order to simplify it down a little bit, it helps to have some categories. First one's traumatic versus atraumatic, simple enough. The second one is the color of the eye, whether or not it's white or whether or not it's red. And the third is vision loss or lack thereof. One hard and fast rule, if you take anything away from this entire talk, is any vision loss should be considered an emergency and should, be evacuated immediately.
First category that we're going to kind of talk about is acute vision loss with a white eye. So they kind of summarized it up into 3 essential diagnoses. First one being the central retinal artery occlusion. So this again presents it with a white eye that's usually painless, and it would have associated vision loss with it. And the cause of this is an ischemic stroke of the retina, which can have, obviously with loss of the retina, you're going to lose vision. And this does present as an emergent problem. And pretty much in the wilderness treatment for this is going to be pretty limited. There's been evidence to support oxygen therapy has been, just inhaled oxygen has been helpful, but it's a pretty low class of evidence there. Second up is central retinal vein occlusion. This presents again with white eye, it's painless with vision loss, and the pretty clinical pearl here is afferent pupillary defect. So essentially, you're going to find that if you do like a swinging eye test here, if you're shining white in one eye, in the unaffected eye, both will dilate, but if you shine a light in the affected eye, because there's no vision there, the eyes will dilate and they'll constrict for in the normal eye. So it would be in both eyes. And this is not specific to central retinal vein occlusion. So it's just like something to be aware of. The cause of this is obstruction of the venous outflow from the eye. If you observe this or have a high suspicion for it, you can administer topical steroids for it. And again, this is an emergent evacuation. Retinal detachment. This is going to be your white eye, painless with floaters, flashes. Pretty much the hallmark here is curtain-like visual field defect, so a descending curtain of darkness that they'll see in the eye. And this is, again, detachment of the retina from the supporting structures, which requires surgical treatment, so there's nothing really we can do in the wilderness for it other than emergent evacuation. Second grouping is periocular inflammation. So 3 kind of big ones here. Preseptal cellulitis, it's going to be a white eye that's painful, and you'll note some periorbital inflammation. The infection is pretty much limited to just the superficial periorbital tissues, and this is going to help you differentiate from orbital cellulitis. The treatment is the same for both systemic antibiotics, and depending on whether it's deep or superficial, it's going to depend on whether or not you evacuate them. So for orbital cellulitis, again, pretty similar in terms of treatment and evacuation, or evacuate for this one, not the other. But the big one's going to be pain with extraocular movement. So if they're having some trouble moving their eyes, that's going to indicate probably a deeper soft tissue infection of the bony orbit or surrounding the eye. And they might also have some visual disturbances with that as well. Treatment's going to be systemic antibiotics, and then for this, you're going to want to emergently evacuate them. For dacryocystitis, pain is going to be noted and redness over the lacrimal duct. This is not an emergent evacuation. A warm compress is probably all they're going to need, and usually these self-resolve. For acute red eye, acute angle closure glaucoma is one of the concerns here. And the clinical relevance here is you're going to note a red eye. It's going to be painful, and it's going to have a hazy cornea with a non-reactive pupil and some increased intraocular pressure. So this is caused by a blockage of aqueous outflow. And the eye is typically going to be mid-dilated, and it does require surgical correction. So some of the wilderness treatment that we can do is topical steroids. If you bring those advanced medications, you can do the pilocarpine, Diamox, and you're going to want to put the patient in a supine position for at least an hour to help relieve some of that intraocular pressure. And this is emergent. And it's the image on the bottom left there that you can see that there's a hazy cornea, as well as the pupil is about mid-dilated. Iritis is going to present with red eye, painful blurry vision, and consensual photophobia. So that is photophobia in both the affected and unaffected eye. And this is going to be treated just with topical steroids, but it is going to require emergent evacuation. And as it can be complicated by scarring of the pupil, as well as increased intraocular pressure. Conjunctivitis, pretty common, if not the most common eye complication that you'll face in the wilderness. It's a red, itchy eye, and you're going to notice the palpebral conjunctiva, so the membrane lining the eyelids, is going to be inflamed. And it might also have some exudate, whether it be purulent, typically from bacteria cause, or more serous, watery from a viral. You'll see that as a discharge, most common in the morning. Wilderness treatment of this, it's going to be topical or systemic antibiotics. Although that being said, most of these are viral, so they might self-resolve. These can also be caused by allergies as well. So if they have a known allergy, that might put you at a better suspicion for an allergic-related conjunctivitis. Hand washing is super important. The viral, especially viral conjunctivitis, is especially transmissible, so avoid that if you can. And these typically self-resolve in a few days, so non-emergent evacuation is okay if it's persistent. For altitude and diving related eye injuries, so the concern with high altitude would be for recent history of a radial keratotomy. Though that being said, there is research to suggest that it wasn't found in all climbers that had a recent history of radial keratotomy. That being said, they recommend extra goggles and glasses if you're mountaineering. There was a mixed bag of evidence with risk for LASIK or PRK procedure. Typically, they seem to be okay, though. The concern is going to be retinal hemorrhage, which is typically white eye and painless. But the literature was pretty wide in how often it occurs, ranging between 4 and 82% of climbers experiencing this. The biggest thing, though, is if there is visual disturbance, loss of vision, anything like that, those climbers should descend. And this is an indicator for impending altitude sickness, so it should be an increased suspicion there. For diving-related eye problems, diving at all is contraindicated with an intraocular gas bubble, which is usually secondary to retinal repair. Though with RK, LASIK, and PRK, it is relatively safe. There was little evidence to support some more severe side effects of that. And then the important thing that they mention is equalizing face mask pressure while you're diving to prevent the significant disparities in pressure between the atmosphere and the intraocular pressure.
All right, so now we've got a few different traumatic injuries to the eye. The first one is orbital fractures. The big presentation you're going to look for here is entrapment of the ocular muscles. So you'll test extraocular movement, and if you were with any question as far as deficit in any direction, that would be a big red flag if you are suspecting an orbital fracture. The cause obviously is trauma to the eye, causing fracture to the orbital bones. Some of the treatment pearls for this is you want to avoid having the patient blow their nose. The idea being if you've got orbital bone fractures, most of those bones also connect with the sinuses. So if you increase the pressure in the sinuses, you could actually increase the pressure behind the eye as well. You can give them decongestant spray and systemic steroids as well. This is going to be an emergent evacuation if you have any of the entrapment of the extraocular muscles. Retroorbital hemorrhage or retrobulbar hematoma. You'll see elevated IOP, vision loss, and APD, just like Matt talked about earlier. So again, that's a non-specific finding, but you will notice that in a retrobulbar hematoma. The cause for this is bleeding behind the eye. It can also cause a compressive neuropathy. Treatment for this is a lateral canthotomy. I think that going through how to do this is probably out of the scope of this talk, but there's actually a pretty interesting article that I posted just below where it says lateral cantholysis about it's a case report where they were able to use a multi-tool and an 11 blade to do one in the field. Evacuation for this is going to be emergent. Next injury is a globe rupture. You're going to have a painful soft eye with a deformed globe and the irregular shaped pupil that you'll see on the side. So you'll see rupture of the structure of the eye, and it's obviously at risk for infection. You'll shield this, and systemic antibiotics and steroids are indicated as well. Again, this is an emergent evacuation. For corneal abrasions, you'll have a red eye, and you'll be able to see this on fluorescence staining. You can see what that looks like in the corner all the way to the bottom right. Treatment for this will be topical antibiotics and NSAIDs. This is only an emergent evacuation if it's deep. You can go to the next slide, Matt. All right, so we did write a few cases. If there's anyone that has any special experience with this or that wanted to go ahead and bring anything up, we could go ahead with that. Otherwise, we've got a couple cases we can go through.
Go ahead and present them, and let's get some participants to work through what they think's going on.
Sounds good. So the first case is going to be a 54-year-old male park ranger who presents with new onset left eye pain. The pain is sharp, rated at 7 out of 10. It's worsened by light and by opening his eye. The symptoms started today while he was weed whacking a trail. He doesn't wear glasses or contact lenses and has never had issues with vision in the past. He denies any direct trauma to the eye. So what do you think that you'd like to know from here, just knowing that?
Is there any foreign body sensation?
He does feel like there's a little bit of a foreign body sensation. He does not wear eye protection when he works. He's supposed to, but he didn't bring it today. All right, so we can go on to the next couple of slides, Matt. So to move on, his vital signs are unremarkable. On exam, his visual acuity and extraocular motion are intact, and a small amount of watery, non-purulent discharge is noted on the left eye. So some important things are brought up here. You definitely want to get a visual acuity exam on these sorts of patients, and probably on every patient that has an eye complaint. And extraocular motion is another important thing to test, because every time we've seen an issue with extraocular motion, that would definitely increase your threshold to evacuate someone emergently. So what are your next steps here? There's one specific test that'll slam dunk this diagnosis. It is green.
Fluorescein testing.
Beautiful. So Matt, if you can do to the next slide, that's what you see. And the diagnosis. Anyone got it?
Lobe rupture.
So
Corneal abrasion.
yeah, corneal abrasion, right. So with a globe, I see what you're saying here. You're seeing kind of like a teardrop shape.
Yeah, it's running. It was running down the cornea.
Yeah, right, exactly. So appropriate treatment. Does anyone have any input on that?
Numbing agent of convenience.
Sure. Yeah. So I mean, if we brought our erythromycin ointment, that would be appropriate. And do we have to evacuate this guy emergently, non-emergently, or not at all?
Not at all.
Right. Only if it's deep or if we have concern for an additional globe rupture. So, the things to key on in this case is, the guy was weed whacking. That gets things, little blades of grass and whatever flying up. He denied direct trauma, but, he also wasn't wearing his eye pro. So, that increases your, the story matches for a corneal abrasion. All right. We have one more case. All right, so here we have a 34-year-old female who's recently recovered from a sinus infection, presenting, complaining of pain in her left eye with associated swelling around the eye. What else do we want to know? Physical exam, story. Just start throwing stuff out.
Does she have diabetes?
Yeah, she can have diabetes.
Any change in her acuity?
Yeah, so she's got a decrease in her visual acuity in the left eye. You also have swelling, and she's actually having trouble getting it open so you can examine it too well. She kind of has to retract her lids in order to open that. Oh, okay. Extraocular motion is intact, but it causes her a lot of pain.
Check her intraocular pressure.
Yeah, so again, difficult to do in the wilderness, obviously, without the tono pen. But if you were to actually just push on the eyes, you can tell that they're grossly the same left to right. You can kind of only compare the two. And then another thing we can, no proptosis.
Can we illuminate her sinuses at all?
Yeah, so she's got tenderness over her sinuses, but we're not really able to illuminate them too well. Do you guys want to see?
Eye red or white?
I'm sorry?
Is the eye red or white?
So it's swollen to the point that you can't really get a great exam on it. Do you want to see a picture of the eye? Why don't you move to the next slide, Matt? So that's what we're looking at here. I'll also give you guys vital signs. She's got a temp of 101.4, a heart rate of 114, and a respiratory rate of 28. So Matt, you can slide to the next slide. What do we think the diagnosis is?
Periorbital cellulitis.
Absolutely. Yep. So exactly. So what is our treatment for this? Antibiotics, love it. And is this someone that we can let continue their trip, or is this someone we need to get evacuated? Beautiful. Definitely an evacuation. With that, we have our references as the next slide, and we can open it up if there's any additional discussion to be had.
I just wanted to cut in for just a moment. I definitely agree the patient needs emergent evacuation, well, urgent evacuation at minimum, but when you have painful or reduced extraocular movement with a fever, I'd be more concerned for post-septal cellulitis than just periorbital. So that's part of the reason you would want to evacuate quickly. You don't usually get a painful extraocular movements with just periorbital or preseptal cellulitis. I'd be worried about a post-septal abscess. So that's the main reason you get them out as fast as possible. But envision if you can even open their eyelids. But anybody else with questions or recommendations, please go away. Go ahead. Don't leave.
So for this, like if you had a patient with cellulitis on an extremity and you would mark typically to check, would you need to do that on their face or not as much so for this type of situation?
I'm more concerned if it's getting closer to the eye. If it's spreading around the face, yeah, it shows it's cellulitis, but it's the eye that you're actually worried about.
So you're more worried about it going deeper rather than
Yeah. Spreading shows possible progression, but I'm more worried about deep than surface area, I suppose.
Do you do like serial CTs or anything then to track it, or how do you follow progression?
I mean, in the ER, if I'm at all worried about orbital cellulitis, I will get a CT with contrast to the face. And if it doesn't show it and they don't have pain with the extraocular movements, their vision's okay, they're not septic, they're not systemic infection appearing, then you can kind of do oral antibiotics outpatient. But if there's that concern with CT, or you just feel something's wrong, or they have pain or any other concerning things, then they need admission with IV antibiotics. But in the wilderness, it's going to be pretty darn tough to tell these differences. So all you've got's the few things we mentioned. They need to go. They need to get out of the wilderness. And then I think the first case was the corneal abrasion case. Has anybody had one, or I
evacuated my child from deep in the Virginia wilderness with a corneal abrasion when he was like 7 or 8.
They're pretty miserable.
Another kid threw a stick and hit him in the eye, and he had a huge central abrasion, verging on perforation.
Yeah. Even if it's not concerning for globe rupture and it's just a large or painful abrasion, it's going to be hard for them to enjoy their trip, function, safely self-evacuate if they're on any concerning terrain. So keep that in mind. topical anesthetics like proparacaine, tetracaine are hugely helpful. It buys them, if you use 1 drop, I don't know, a couple dozen minutes. If you give them 2 to 3 drops, you get a couple hours of comfort, and that alone might be able to have them self-evacuate. So I would strongly recommend keeping something like that in your pack. What else is anybody other had questions during the topic or any recommendations?
You did one likely abrasion on one of my another firefighter on my crew several years ago. Unfortunately, we had a lot of saline around that we could help to wash out any foreign objects that had gotten in. He didn't get hit by anything that we could tell. He just a lot of dirt and dust in the air. Something got in there, but eventually he did have to get evacuated. But fortunately for us being on a fire crew, we had vehicles and roads and everything else, so it wasn't a typical backcountry wilderness situation.
And just like lacerations, my old attendings always like to say is the solution to pollution is dilution. So if you want to get the foreign bodies out, you want to get the dirt and grime out, it just has to be potable quality or above water. It doesn't have to be sterile. The studies show even with lacerations, you can just use tap water. Eyes are different, I suppose, but if you have the volume and you're not gonna like run out of water personally, then you can definitely flood the eye. Also, we didn't mention, the guidelines don't mention it at all, I don't think. Has anybody done an ultrasound of the eye?
Yes.
And what would be a good diagnosis you could pretty easily detect with a ultrasound here that we talked about earlier?
Detachment.
Mm-hmm. I've done it. The portable ultrasounds are getting somewhat affordable now, so if you've got it, you can pretty easily detect retinal detachment.
You see vitreous hemorrhage as well.
Mm-hmm. I'm not personally good enough to notice a vitreous versus a retinal detachment, but if I see
vitreous is more diffuse, and the retinal detachment's got more like serpiginous linear features.
Mm-hmm. Otherwise, the main thing is like it's essentially a potential loss of vision or eye. So if you're concerned and there's a danger, you want to get them out. All right. Other than that, I think we can move on to the first article unless anybody has any other points they want to make. All right. Who wants to go first? We've got 3 separate articles to run through. Don't worry, they're all actually really short, like 3 pages or less.
I'm happy to go, Justin.
Go ahead.
Suppose I can do camera. Hey everybody, I'm Justin. Share screen.
You should have permission to.
Yeah. There we go. All right. Slideshow. Everybody seeing that? Cool. So the article was an investigation of ultramarathon associated visual impairment. There's the authors, there's me and all my letters. The sort of just background on this, on why the authors wanted to study this, and some definitions for you. So ultramarathon defined as a running race longer than a standard marathon, so longer than 26.2 miles. The most common distance is the 100-mile distance, or 161 kilometers as the authors talk about it. I found it interesting that there is a 3,100-mile race called the Self-Transcendence that's run just around a couple of blocks in New York City. Just so you know, it's usually involving multiple aid stations. These are, with this distance, is usually in a wilderness environment and varying levels of support. Obviously, a variety of temperature extremes, weather, altitude, and popularity has been skyrocketing over the past decade or so, while like participation, things like 5Ks, things like that are going down. Ultramarathons are going up. So why they wanted to present this study. So there have been sort of anecdotal reports of just lots of visual impairment, during these much longer races. Again, we're talking 50 to several hundred miles over several days, trying to figure out like why it's happening and what the risk factors are for this. They kind of looked at corneal edema as the most proposed mechanism. And some other literature and research has been shown to be associated with cold, dry, windy conditions and things like long distance cycling and pursuits similar to that. But nobody had really looked at it in detail in ultramarathoners and just a different level of stress and different level of different physiologic basis. So in case you need a reminder of your anatomy, and you just don't remember what the cornea is, so it's that outer layer of the eye. It's a transparent that light passes through. And so if there is swelling or opacification or edema or any sort of damage to the cornea, you can get an awkward or altered refraction of the light as it's coming through the cornea and to pass through the lens, and that can present usually as blurry vision or cloudy vision, and sometimes various other findings depending on how people describe it. So in case you needed a reminder on your eye anatomy. So what they did was an internet-based survey. They posted it on websites, social media platforms frequented by ultramarathoners. They asked anyone to report any significant visual difficulties during a race. They got some basic demo, how many races they've done, the length, as well as some medical and ophthalmological history. As a reference group, they used the 2013 Western States Endurance Run, which is a 100-miler out in California, as kind of a representative sample of their runners to compare against the folks that reported in. So kind of in the results, the highlights from the folks that responded, 173 of them, most of them from the US, more than half were men. And as you might expect from people running extraordinarily long distances, they had actually pretty low rates of, comorbidities, diabetes, heart disease. I found about a quarter of them wear contacts, and just under a quarter of them have had refractive surgery in the past. And what they basically found in the reporting was that there were 779 total reported episodes. So of people that reported them, a median 2 episodes, but they only had real good details on 218 of them. The interesting thing there, so the history of refractive surgery had a higher median number of episodes. A couple of environmental things, that 32.4% at 2,000 meters or higher in altitude. About a quarter of them reported significant wind, but there were no associations with cold or hot temperatures. You can see there's the most common symptoms that folks reported on the form, and these were in the form of check boxes, so they could choose which symptom they had. But up there, obviously, cloudy or foggy vision and blurry vision being the most common. But there's halos down there, and if you know anything about glaucoma, it makes you worry. The folks that had their visual impairment normal at the end of the race was substantially lower. The vast majority of them persisted after the race, and then the median time to improvement after the race was about 3.5 hours. Interestingly enough, only 10 of them had actual evaluation by a medical professional afterwards, or like by an ophthalmologist or somebody skilled enough to do an eye exam. And so there, of those 107 or 779 episodes, only 10 of them actually got diagnoses. So 8 were diagnosed with corneal edema, and 2 of them were diagnosed with corneal damage from contact lens use. So the stuff that was important, I won't read the quote to you there, but basically saying that this ultramarathon associated visual impairment is, it's painless vision changes that resolve spontaneously, and then folks that have had refractive surgery, seem to have it a lot more. One of the thoughts there that they talk about is that a thinner cornea that is present after refractive surgery leads to increased edema during stress, and that's maybe due to like a purported higher oxygen consumption by a thinner cornea. There were very few apparent environmental factors. The only ones that reported were those, sort of minority that had high altitude or really high wind levels, but temperature wasn't associated with much of anything. No other real weather conditions. And interestingly enough, there were no increased risks for contact lens wearers. And there's some thought that like maybe this is actually a preventative measure against corneal edema. And there's an older bit of literature from 1992 that looked more at cold weather cycling, and they found that wearing contact lenses actually helped to reduce corneal edema and long distance cold weather cycling. And kind of the big so what, the possible explanation that they give is that there is this increased metabolic activity in the cornea from all the stress and multiple stimuli and, just running for a really, really long time. And, I think the interesting thing to me would be, how could you think about preventing this? And they did ask about that on the survey. And so the questions there would be just, are eye drops preventative? And some folks reported that they would rest be a preventative thing, which is hard to do in the middle of an ultra marathon. Is there some sort of protective eyewear? Some folks reported closing their eyes regularly actually helps to relieve some of the symptoms. And you got to wonder if like wearing contacts is actually maybe a strategy for preventing this in the future, especially if folks have experienced it before. They indicate that the visual impairment is probably self-limiting, but you have to wonder about and be concerned about if you're working in this environment and working one of these aid stations or evaluating these folks, these environments, 21.2% of folks reported that their vision loss or their vision impairment included halos, which is kind of a classic finding for acute angle closure glaucoma. And so being concerned about that, corneal abrasion that, the guidelines just talked about has, an entirely different, assessment and treatment process than just a self-limiting bit of corneal edema. And then anyway, with kind of blurry vision, especially in a painless setting, like worrying about central retinal vein occlusion. So without true follow-up on these folks and not getting a lot of, ophthalmological follow-up or emergency department follow-up on these folks after they had these episodes, like begs the question of what happened to the other 769 individuals in there. And so then you kind of start to wonder, how manageable is this in the wilderness? Well, if it is self-limiting and during the course of a race, it seems like it's very manageable. And, kind of thoughts on evac for these kinds of cases would be that as long as it's something that's self-limiting, but if somebody was experiencing it multiple times and it kept happening over multiple instances, or it was recurring and relapsing, relapsing, with things that I would think would be more concerning. So it's a very short article. There's a couple of references, and I will stop sharing.
Has anybody run an ultramarathon or seen a patient with one of these conditions from such a long endurance event?
One of the things that they made sure to exclude on the survey was that the visual impairment they were talking about should not include hallucinations. And that's with my experience doing event medicine in the past, that's the only visual impairment that has ever actually been reported to me with somebody at an aid station was that they were hallucinating because they were, heat stroking. But they specifically said, don't report that one.
I just put a link to a picture in the chat. It's of a patient with corneal edema from an ultramarathon. So you can see one eye that's his normal eye and the other eye is the affected. And the picture would be on the right, his left. So it's interesting that the articles I read, and one of which he just presented, mentioned that temperature wasn't really involved. When I did medical race support for one of the Virginia-based ultramarathons called Hellgate, it's 66 miles. It's usually really cold because I think it was December or November. I can't remember, but typically it's like frozen.
January.
Is it January?
The article. Yeah.
They all run together. It's usually like ice on the ground, snow on the ground. People get the corneal edema, and the theory at the time was that it was from the cold, but you actually look at the statistics, and it doesn't seem that temperature truly has that much to do with it. So interesting that they actually call it Hellgate eyes. So sometimes you wonder where medical myths come from, and that's kind of how they happen. But that's at least what it looks like. Kind of hard to differentiate from the pictures of glaucoma, but you shouldn't get the redness in the eye. Any questions about the article? Electrolytes. I mean, electrolyte balance would deal with pressures in the eye and thickness of the cornea, but I'm not sure.
One prior proposed mechanism for some of the corneal edema was the hypoxia leading to a buildup of lactate, which acts as an osmolyte and drawing fluid into the corneal space. I can't find any evidence for that. Then I think that kind of goes with the electrolytes of like if there's an electrolyte balance and a fluid shift due to that. But they certainly don't talk about it, and I've never seen anything about it.
I guess physiologically, a look at it, like he was saying, you could make sense of it, I suppose, or theoretically say like, oh, that's probably what happened, but I don't think there are.
Yeah, the paper that I'm actually going to present, they mentioned that this sort of edema is, they say, well described in patients over 6,000 feet, or 6,000 meters. But I wasn't able to actually look into the results. But it's like a very similar mechanism to what Justin was describing.
Well, since it's so well kind of segues over to it, Jason, why don't you take it away? And I think it'll pretty your article.
Sounds good. Let me fix my screen here. Wait a minute. Sorry. All right, everybody got my screen? Cool. All right, so my paper here was a case report of a corneal opacity in a participant of a 161 kilometer, aka 100-mile mountain bike race at high altitude. This was a case of a 56-year-old male developed blurred vision while participating in the Leadville 100 mountain bike race. I was actually kind of excited to get this paper because I really wanted to do this race for a long time, but I can't quite fit it in my schedule. So, sorry, I don't know how to move screens here. Give it a sec. All right. So Leadville 100 is, like I said, a 100-mile mountain bike race held in Leadville, Colorado every year. It's conducted on a combination of paved roads, dirt roads, and trails. Altitudes up to 3,800 meters, so very close to 14,000 feet. And lots of hazards along the way, including a lot of dust, flying debris, lots of things to get in your eyes. This was a 56-year-old male who developed painless unilateral blurred vision that actually forced him out of the race at mile 95. He had an ophthalmologic history, including keratosis, myopia, and astigmatism. When he came into the aid tent, he was noted to have a left-sided corneal opacity, which is seen here. It's sort of the medial side of the left eye that was clouded. On their exam, they found that he could detect movement in the eye, but he wasn't able to read wasn't able to count fingers at about 10 feet. And they couldn't test his depth perception because of the loss of his acuity in that eye. They did notice no conjunctival injection, no foreign object found in an exam. And then he did say it was a painless occurrence. So without being able to do a full optical exam, ophthalmologic exam, they did rule out a corneal abrasion just due to the lack of pain. So they diagnosed him with a corneal edema. They also noted that the rest of his exam was normal, his vital signs were within normal limits. They didn't say anything about hallucinations. This patient's particular course said that he had about a 25% improvement in his vision in about 6 hours. And then he reported a 90% improvement 2 days later with a complete resolution at 3 days. He was supposed to go in to see an ophthalmologist for follow-up, but he canceled it because his vision returned to normal. And then he reportedly returned and completed the race the following year without any recurrence of the problems. For a discussion, the authors report the incidence of these visual problems is actually unknown. They did report one study that showed 3% of 3% of participants in a 100-mile ultra marathon had visual problems that were severe enough to impact performance. It seems to be a fairly a high rate of occurrence. It was knocking 3% of the participants out of these races. The authors further stated that painless blurred vision was the most common complaint, and suggested that corneal edema is the common cause of this painless blurred vision. But they did list possible etiologies and then some other specifics to this one case. Possible etiologies include acute or chronic trauma, chemical exposure, inflammatory processes, and hypoxia. As for this particular case, this event involved a very high altitude, long distance racing that involved dehydration, increased sun or UV exposure, low oxygen tension due to the altitude, low barometric pressure as well, and then cold and wind. As far as the more specifics on these etiologies, of course, trauma could be associated with this, all the dust, the flying debris of on the course, any sort of crashes that the participants endured. Doesn't seem to, in my mind, lead to a painless vision loss. I would really expect that to be much more of a corneal abrasion or foreign objects. Chemical exposure, they noted that the participant had used an aerosol sunscreen and bug spray as well. The authors thought that this may be contributing to more irritation in the cornea. Hypoxia, this is what I was just talking about. They said that corneal edema is well described in climbers over 6,000 meters. Like I said, I didn't have time to look into the details of that. It would be pretty interesting connection between these two papers. But they briefly summarized it. They thought this was thought to be related to hypoxia with a metabolic dysfunction leading to stromal edema. And then they did note, like the other paper, a strong connection with ophthalmologic history. So patients that had refractive eye surgeries had an increased risk of visual disturbance in these races. They theorized that that might be related to the high altitude wind or increased sun and UV exposure. So if you do work in one of these races, they briefly covered the evaluation of the racers if they come in presenting with blurred vision. Of course, do a basic assessment of them, assess their vital signs, do an appropriate physical exam, look for any other possible causes of the blurred vision, including dehydration, ultramental status, and then consider anything else that would limit the racer from completing the race. As far as the eye exam goes, of course, looking for obvious trauma, any conjunctival injection, foreign body. I think the guidelines that we covered to start this are actually excellent for that, whether the white versus red, traumatic versus atraumatic, painful or not. This in particular, this case would present as basically just a clouded cornea. And that is what I've got. I think another thing to consider as far as like evacuation, determining what you're going to do with patients in this setting. It's also really important if you're looking at racers in these long endurance races. These run 24 hours or 48 hours. They're racing at night. They're racing over rough terrain, steep terrain. Anything that's going to interrupt your visual acuity might not prohibit you from continuing on in the race, but if it leads to crashes or injuries later because you're unable to really see where you're going, unable to you lose a lot of visual acuity, especially in low light or after sunset. Like that's a pretty concerning thing. So maybe not an immediate evacuation, but certainly a thing to consider anytime that you're going to be looking at somebody working in difficult terrain or in low light conditions.
All right, any questions about those two? They tie pretty well, but they also kind of like further expound on each other. So any questions or points about those two? All right, real quick, everybody mentions it in all of the articles and the guidelines about about why radial keratotomy is the higher concern. Does anybody know why? There's like 3 corrective eye surgery procedures: LASIK, PRK, and radial keratotomy. You know why radial keratotomy is mentioned more often? I'm going to share my screen real quick. can everybody see this picture of the guy with the corneal edema? I'll say yes.
Yep.
So this
Sorry,
is,
yeah, we can see it.
that's fine. That's a patient with history of having had a radial keratotomy. So basically what they do is they make slices in like a clock face pattern through the cornea that you see here. So you have circumferential linear defects in the somewhat dome shape of the cornea. So why do you think that would be more apt to change whether you're at depth diving or going to altitude? There's no, like, it's more a question for like architects or engineers, honestly. Like, it's not a medical question. You got a dome and you make it weak. So you make it's structurally weak. So it's more prone to edema or pressure changes, whether it's high or low altitude or depth. So that's essentially why it's higher risk. And it bothered me for a while until I actually looked into it. So this is why. And to further expand on it, this is, well, I'll go LASIK first. So LASIK is probably the most common. So it's actually a thin, I'll expand it a bit for you, thin flap, like a can opener that they make through the cornea. And they retract that, they shoot the laser through that. Once they're done with the laser, they flap the cornea back down. They do not reattach it. So it's there by like the pressure that is exerted on 2 layers of like wet surfaces. So the inner and outer surface of that film is both wet, so they attract. Somebody probably knows the true like physics definition of the name for that, but water attracts water essentially, so it keeps it like hydrophobic pressure, I think is the name, or hydrophilic. So it's not firmly attached. Actually, that flap can come detached with blunt force trauma like jujitsu, punches to the face, kicks to the face, that can detach. Whitewater rafting. And it's also, you can't consider this flap as a component of the cornea's structural integrity. You can only consider the layer below it. So LASIK is the next most prone to pressure changes at depth or altitude. So the typical average corneal width is 540 micrometers. Yeah, microns. So this flap is however many dozen or 100 or 2. So that's the difference between that and 540 is what's left. So it's thin, but not super weak like with radial keratotomy. And this is PRK, which is the third most common. Or sorry, it's the second most common after LASIK. PRK, there's no flap. They take this tiny little metal tool and they like scrape away the layers of the epithelium of the cornea. They don't go all the way through, of course. They take off, I don't think they take off more than 100 or 150. And then it grows back because it's just a scrape. It's like an induced corneal abrasion that can grow almost all the way back. So that's the least likely to have pressure changes at altitude or depth. So I just thought I'd explain it a bit because it had bothered me for a long time and I was curious. So that's, has anybody read the book Into Thin Air?
Yes, Beck Weathers.
Yes. So Beck Weathers, he had radial keratotomy. And I don't know if he hid it or if they didn't ask about it in his pre-trip planning or medical history, I don't know. But he had radial keratotomy, I believe it was 2 months before his attempt of ascending Everest. And Douglas, I think you can attest that he had a pretty poor outcome.
No doubt. And totally blind too in the process.
Yeah, they said he just had, or he downplayed it, of course, because everybody wants to, you don't want to call it macho, but they paid like 60 grand to go up there. Traveled from across the world to ascend. It is like a personal pride thing, I suppose, but he essentially went blind. I think he said he couldn't see more than like 2 feet in front of him or 3 feet in front of him. And then he ended up getting kind of abandoned by his co-climbers and got really bad frostbite to the point he lost his nose. I think it was the distal half of his forearm and below, and then like the other hand, all from frostbite. So very important to ask your trip members about their vision and have, like the guideline presenter said, have your patients with a history of eye problems get a thorough optometry or ophthalmology appointment before they go, because he probably would have been fine if he didn't have altitude pressure changes from his radial keratotomy. And then I think a couple other people might have done better as well on the trip. But anyway, we've got one more article, and I didn't send it out in the emails. I did put it on the Google Drive. So this one's kind of, I don't want to say a surprise, but I think it's probably the most, you'll get the most reactions from this article, I suppose. Go ahead.
Okay, let me see if I can share my screen. It is making me change my settings, so hold on one second. And I don't know how to do that. Does anyone know how to change screen sharing on a Mac? No? Okay, cool.
No, but I just brought your presentation up so I can screen share and you can tell me when to go to the next slide if you want.
Okay, that works. Hold on one second. Sorry about the barking if that happens the entire time. Goose. Yeah, he's fine. Okay. All right. So this one is on orbital compartment syndrome, and it is alternative tools to performing a lateral canthotomy and cantolysis. It's a case study. So they started the article off with a case. The patient is a 46-year-old male who is presenting to the ED with blunt cranial and orbital trauma. He was unconscious when he arrived. He had a Glasgow coma scale of 5, obvious proptosis. When they did the exam, his pupils were midpoint and non-reactive to light, left eye proptotic and resistant to terrestrial repulsion with light digital compression. We were talking about the tonometer earlier. They did not have one. So the whole point of this article is they're doing this procedure in a resource poor setting. The ophthalmologist was also not available immediately. So the physicians in the ED decided that they needed to do a cantolysis and canthotomy with the tools that they had available. They did not have the standard tools that should be used when performing this type of thing, but they knew that the patient needed this procedure done. So they did what they could with what they had. And that's the point of what this case study is about. So orbital compartment syndrome, the most common cause of, go back one slide. The most common cause of orbital compartment syndrome is retrobulbar hemorrhage. The other causes are up on that table on the left-hand side. One of the big problems with orbital compartment syndrome is the damage that can be done to the optic nerve because it's so sensitive to decrease orbital perfusion pressure, and so is the retina. So there can be serious and possibly irreversible damage to vision with permanent blindness within as little as 90 minutes to 2 hours. So how do you identify orbital compartment syndrome? Typically, the patient will present with a history of orbital or facial trauma. They'll have eye pain, decreased visual acuity, possibly diplopia, lack of motility, so their extraocular movements will be limited or possibly completely gone in the affected eye. They may or may not have the resistance to the digital orbital compression if you don't have a tonometer available. I put plus or minus because it can be so subjective and doesn't necessarily rule things in or out. Same with the infraorbital hyposthesia. You may see it, but you also may not. And if the patient is unconscious, it's not really going to matter. Some of the other symptoms would be proptosis, ecchymosis around the eye, blood ecchymosis, IOP of greater than 40 millimeters of mercury, which is a lot higher than normal. They would have the resistance to retropulsion if you can't actually measure the IOP. They may have some diffuse subjunctival hemorrhage, and they may have an afferent pupillary defect. Less definitive signs of the orbital compartment syndrome are going to be marked periorbital edema, crepitus, cherry red macular optic nerve pallor. So the intervention that they went with is the lateral canthotomy and the canthelysis. So in a standard treatment setting, what you would want to do is elevate the head of the patient to help kind of decrease intracranial and intraocular pressure. And you would want to leave them in this position if it's tolerable for them during the procedure. You should give sedation, especially if they're awake. The tools that you would use in your standard treatment setting would be a Kelly hemostat. You'd also use an iris or similar small scissors. They did mention them being blunt tipped so you don't damage the eye. And the procedure is going to involve using the hemostat horizontally around the lateral corner of the eye, putting one blade under the orbital skin, and you would clamp that. And this is going to stop any bleeding that occurs, but there should not be a bunch of bleeding with this type of injury. And it's also going to mark the incision line where you're going to cut with the scissors. So you would divide the lateral canthal tendon band, and then you would pull down, pull the inferior and then superior eyelids away from the globe, and then cut those other tendons. And you would repeat on the upper eyelid as well. And that is a gross picture of that happening. So the first one is where they're going to put the anesthesia and where they're going to cut that tissue. The second picture on the top is where they're actually cutting that lateral tendon to release that pressure and release the eyelid. And then you would do the same thing. C is them doing the same thing, pulling the lateral or the lower eyelid down, and then they would cut that inferior tendon. And then after cutting the inferior one, you would most likely do the superior one.
Was this a living person?
This person, I don't know. It was just from the article.
Yeah. I'll keep moving.
I have a video of them doing one too. So the contraindications to this procedure would be a suspected globe rupture. It's frequently cited in the literature, but there's not really any evidence to support this. And the authors countered against that by saying if there was a globe rupture, there would be low intraocular pressure and the eye wouldn't be popping out as much. So you wouldn't really necessarily suspect it. And it's really unlikely that the retrobulbar hemorrhage, or the most common cause of this, would even be emergently identified in this type of injury. So there's not really a contraindication with any evidence to support it anyway. So in a resource poor setting, you would supplement the tools. So instead of using the hemostat, if you don't have it, you would want to use a multi-tool. If you want to do the math, there was a bunch of math listed in the article for how to measure the different things, but I don't think that the ED docs did any math before they decided to use this tool, honestly. So I don't think you need the math. They mentioned you can use pretty much any local anesthetic that you have. And then if you don't have the iris or small scissors, you could use an 11 scalpel or a similar knife blade, or some small blunt tipped scissors, like I said earlier, so you don't accidentally stab their eyeball and cut it open. So they went into a little bit more detail on the procedure in the resource poor setting. So you would leave the hemostat in place, or the multi-tool in place. Exactly, Justin. You would leave it in place with the one blade inside the eye to use as a tool to prevent the scissors or the scalpel from cutting into the eye, kind of like a block. And also it will confirm that the tissue has been completely cut, because it will be able to quickly go through once the complete incision is made. The lateral canthotomy usually also needs to have the canthelysis with it, with inferior and usually superior tendons done, because the lateral canthotomy itself is not usually sufficient in decreasing the intraocular pressure. So that is what you really need to focus on, is getting that down so that they don't lose their vision. In the patient case that they had, they didn't have a tonometer to even check the IOP, so they just immediately went and proceeded to doing the canthelysis just to be sure. They used the dull black side of the blade to push the alveolar tissue aside until the resistance was felt. Then they flipped the blade over and actually cut it. And then they repeated that for the superior band as well. If the eyelids are freely mobile, you have success, and then you should be treating with systemic antibiotics, especially if you're outside in the woods, until you can evacuate them. So what happened? The ophthalmologist, when they finally got there, they said there was a perfect procedure. They did a great job, but the patient died anyway. He died of his cranial injuries. He never regained consciousness. But they found out that they did the procedure right and that it works if you substitute these tools. Possible complications of doing this procedure are iatrogenic globe injury, ptosis secondary to the levator aponeurosis being injured. You can injure the lacrimal gland or artery, bleeding, infection, and ectropion if there's extensive canthelysis, so if they cut it too much. And there are a couple alternative treatments that they listed in the article, but none of them seemed to be really recommended. They did mention medical treatment that could be used if you can't immediately surgically decompress, or if the intraocular pressure is still raised after decompression. But again, they said it's not recommended. So you could use mannitol, acetazolamide, or methylprednisolone. You should be treating the associated trauma as well. Local wound management, antibiotics, and tetanus immunization. Tetanus immunization seems to be pretty standard. And then you should also consult the eye doctor immediately after you're done with the procedure and get them there as soon as possible. And they will usually close the cuts that you made within a few days when swelling has gone down, if everything is healed. And that might be the last slide.
Yeah, I'm not able to click forward, so I think that might be it.
Okay, yeah, that might be the end. I can bring up all my references, but I guess I did not put them in there.
Okay.
And I did have a video. If anybody wants to watch, I can just put it in the chat.
It's probably good to watch. Has anybody seen one or done one?
Justin is Doug. I've done about 100 in the cadaver lab and 4 or 5 on real patients.
Yeah, I've done a handful on cadavers, and I've assisted with one on patients. Do you have any tips for those of us who've done it or seen it none or
yeah, I pull using forceps. I pull the lower lid straight up towards the ceiling, and then using the tips of the scissors strum through the alveolar tissue to find the band, which you cannot see. Don't expect to see. This is a tactile procedure. And typically, in my experience, just doing the inferior is sufficient to lower the pressure. Although I get it, in the austere environment, you're not going to be able to measure pressure.
The main reason, Becky, I was asking if the patient was alive is because the one I saw it was done by an ophthalmologist. Like, it was actually a plastic. What was his subspecialty? He had so many. He was an ophthalmologist, but he was also like a plastic surgeon. He did oculoplastics.
Yeah, oculoplastics.
And it was a bloody mess. So that's why I was asking if that patient was alive, because.
Oh, they kept saying in the article that it's not supposed to be super bloody, but I guess maybe their patient already lost a lot of blood.
Douglas, when you've done it, are yours bloody?
A little bit, but it's more you just can't see the inferior crus.
Yeah, it's
So
definitely, they say it feels like a guitar string. I
Yeah.
felt it. It's not like you have to be delicate. Don't be like strumming. You're strumming lightly.
It's not as obvious as you would hope, but it's
Yeah.
there.
And on cadavers, I mean, you preserve it as well as mine was fresh. It was not preserved.
Mine are all fresh, and what I do is I take 10 to 20 cc's of water and an 18 gauge needle, and I inject retroorbitally to make the proptosis and to make chemosis, because otherwise it's not realistic. So I go underneath the orbit with the needle, inject I just get water from the cadaver lab sink, and then the eyeball pushes out, and then you get chemosis, and then it's very realistic. Aside from there's not any bleeding, but aside from that.
Yeah. All right, Becky, why don't you show the video? If anybody's squeamish, they can, I guess, look away. But
Oh, I can't share my screen, but I did put it in the.
okay, yeah. So everybody can watch the video.
Or if you want to pull it up and share your screen.
Okay,
I don't know why my computer's not letting me do it, but
Let's see if it's working for me. Oh, Jess Mason. I wanted to get it pulled up so we weren't sitting around for a little bit. So the point of this session is not lateral canthotomies. It was just something to talk about, but I do still have it here. I apologize. It pulled up Microsoft Edge for some reason.
Dr. Jess Mason, and this video shows illustrations and research of a lateral canthotomy. That's a procedure to relieve ocular pressure when you need to cut. And remember, 40, that's 40. It's the intraocular pressure when you need to cut, release the compartment syndrome. Let's go through the steps of the procedure. First step is you want to get it numbed up. So lidocaine with epi, be a nice doctor. Second, you're going to crush the lateral canthus with a clamp. This devascularizes the area. Now, here it is in the real procedure. You want to leave that clamp there for about 1 minute so it doesn't bleed like stink when you cut. And that's coming up in step 3. Cut the lateral canthus. You're going to cut towards the orbital rim on the side.
See, it's like usually you can't see it. You can just feel it if it's too small.
Next, you're going to cut that lateral canthal ligament, which has both a superior and inferior crus. Sort of looks like a wishbone on its side. You want to cut that inferior crus first. Sometimes this releases enough pressure on its own, but if not, cut the superior crus. Now, it can be real hard to see, even for you, not just the patient. There's a lot of blood, oozy stuff. So get in there with one of your instruments, get some tactile feedback. It sort of feels like a guitar string.
Yeah, it feels like it's done.
At the end, recheck your intraocular pressure to make sure it dropped, and this is how it should look when you're done.
Yeah, I don't know if my ophthalmologist crushed and devascularized for long enough. But I think another tip is if you haven't seen a significant retrobulbar hematoma or post-septal cellulitis with significant edema to the eyelids, it's hard to open them. It's almost sometimes a 2-person job. You can use the paperclip tripper. You literally just bend paper clips. The curved part is what you're using, and you hook in and retract. Of course, the ophthalmologist brought down his fancy retractors, but you do what you got to do, and you want to get pressures. And sometimes that's tough because the patients, there might be having a depressed GCS, and it makes the exam easier. They're not going to move on you, but it's still hard to open those eyelids. And if you have the old-fashioned tonometer, where it's like the tono pen, where you got to like get it perfectly vertical and touch it perfectly central in the pupil while you're retracting, it's tough. And then the other version, it looks kind of like a fake gun. That's got to be almost, patient has to be almost vertical. So you have to kind of plan accordingly with your utensils. And I actually think the tono pen might be easier in this case because you want them flat. I'd say it's definitely a 2 to 3 person job. my resident did some cutting and some retracting, and they did the inferior cruce, rechecked pressures, and I think pressures went from like mid 50s to mid 40s after the inferior crust was cut. So they went up and did the superior as well. And then it just, pressures really plummeted. So they had to do both. My patient was, I think he was somewhere in his 60s, beaten the head with a metal pipe by some disgruntled, I think it was a coworker, maybe he was an employee, I can't remember. But yeah, it's usually pretty obvious that something bad's going on when you look at them. It's not usually a subtle finding and you're like, I wonder if it's going to be high, but it can be. That's why I always check pressures on these people. Any other questions or tips about eye injuries or illnesses when you don't have all the resources of like my tertiary care center? Would have been different if I didn't have oculoplastics like 3 floors above me.
I think the main thing we don't always bring with us is a topical ophthalmic anesthetic. Because without that, it's miserable.
Or just, and definitely bring like piperacane, tetracaine. In almost every hospital I've worked, it's required to use them one time. You get your little vial and you only get to use them for one patient. You can't send them home. Before I get onto that segue there, does anybody know why you don't send patients home with topical anesthetics for the eye? So patients would like it. I've had corneal abrasion. It's miserable. You want to not feel it, but it significantly delays healing is one reason. And that's the main reason. Any board question you ever see, if it mentions the possibility of sending home with topical anesthetic, answer is most definitely no. I've had patients beg me to take that bottle home with them and I have to like hide it from them. So just remember, don't let them have it. Anyway, just.
I've also been told by our ophthalmology group here, at least, that they don't like patients going home with them because if they need to keep using it for days and days and days to control the pain, they actually would rather have them come back in and be seen by a doc. Something else might be going on too. And
that's pretty much with any, I mean, from the ER, I don't like giving people more than a couple days worth of meds because I want them to see their family doc. No. Or come back if things are worsening. So, and yeah, if let's say you're numb, you have a corneal abrasion or a foreign body, you don't feel it and you're just sitting there rubbing. So you're possibly worsening an injury. Those are kind of 3 pretty quick answers for why you don't give it. But saline drops, I would definitely recommend keeping just eye drops. And I'd say, I mean, I've been using a lot lately, so always these little preservative-free use ones. You can get a box of them and keep them in your bag for when you go out. But the big bottles, they can get gross and dirty, but they have preservatives in them. I think that's one of the glycols. I can't remember which one. But it can cause further dryness and itching if you use it for like a couple days even. So not great if you're already trying to treat a problem that causes continuation of the problem. And I think it was mentioned in the guidelines, I'd also recommend anybody that wears contacts, if you're going on a backpacking trip or extended trip of any kind, single day, one-time use contacts. I would not bring multi-use. I've done it. It's not fun. Just I wash my hands with soap and water, and then I clean them with water, then I use like antibiotic gel, and then I rinse them a couple more times, and then you finally do it. It's just a miserable process. Just get single one-time use. Any other questions or tips? Eye injuries is not like the super fun topic of wilderness medicine, but it's very important because you can't see, it's going to be a kind of tough trip.
I think, my approach, and I touched on this when I was an EMT in the field, was just because somebody doesn't have an injury that means that they need to get evac'd or medevac'd right away. It's a huge impediment to whatever they're going to be doing in the field. Like I was saying on the when I was presenting, was think about the complications that can arise from poor vision throughout the rest of the time they're out in the field too, even if they're kind of comfortable. It's I've been rereading Deep Survival recently, and it makes me think a lot about the complications that come from other small minor issues.
Yeah. So I think the mentions we've made about like just adjustments to your own pack contents and preparation, I think it's a good thing to remember for if you're like medical support for a race. Like I'm going to be helping out with, I mean, it's a 5K. If there's too much that happens on this 5K coming up, I'm going to be a bit surprised. But if you're helping out with the ultra marathon or even a marathon length or medical expedition trip or something like that, like definitely remember eye stuff. I have a kit just for eye. The drops you were mentioning, I got mine at, I think it was CVS. Fluorescein strips, if you can find them, are definitely something you want to bring. Kind of harder for me to find. Does anybody have an easy suggestion other than questionable means of getting fluorescein strips?
Probably order them for like Boundtree or somewhere.
Yeah.
I haven't looked, but I suspect.
Yeah.
Do you have anything that to actually visualize fluorescein with then in the field?
They make pen lights that are UV. One of my co-residents, you know, that big lamp, the Woods lamp you've got to carry it. It's an awful thing. The bulbs are always half dead. He just bought one of those and he kept it in his pocket with his regular pen light. And it worked just as well. And patients always stare at you while you're using the Woods lamp, like, oh, which button is it? There's like 4 buttons on it and they never work.
It's always the last button. I think you can see a big abrasion without it anyways.
Yeah. And clinically, I think you'll kind of realize that it's probably an abrasion. I would say from personal experience now, my wife probably thinks I'm a giant baby and teasing me for saying this, but I had PRK like 11 days ago. So that's the one where they like scrape the surface of your eye and they surgically induce an 8mm corneal abrasion on each side. And it was the most miserable I've ever been. So I used to just be like, yeah, it's just a corneal abrasion. It'll be gone in a day. Don't worry about it. It sucks. It's horrible. So if you've got a patient with it, I wouldn't send patients home with a proparacaine, but if let's say they're like, you're 20 miles out, there's no quicker evac than a self-extrication hike. Like you're going to want them to feel comfortable enough to help you. You're not going to want to carry them and make a litter. So I'd bring drops and I'd give them enough to get by. As you can't open your eye, you can't see, and you lose depth perception alone. It's going to be tough. So eye stuff's nothing to kind of mess around with. But all right, I think unless there's any other questions regarding eye stuff, I'm going to stop recording. All right, well, thanks for joining. Doesn't mean end a session. It just means end a recording real quick.